but we are happy to have Dr. Bansal here to talk with us about the care of the trauma patient. He just literally got finished with surgery, so I hope he has a second to catch his breath and provide us with some new information. So please welcome Vishal.
Thank you, everyone, again for being here. I actually am not done. We're still mobilizing the right colon, so as soon as I finish here, I'll run back to the patient. Let me just give you some important points that I think we should, in this forum, come away with in the pregnant trauma patient. Because as you know, we see a fair amount of pregnant trauma patients, and I'll show you some numbers from UCSD over the last 20 years to justify that statement. Remember, the first and most important thing is priority must be given to the mother. You don't think of the pregnancy so much, think of the mother, because if you save the mother, you save the baby, and that's what you have to remember, okay? If there's anything you take away from this discussion, it's save the mother, save the baby. Pregnant physiology is unique and should be appreciated, and obstetrical consultation should be obtained properly, as we do very well at UCSD. In fact, it's probably one of the most rapid and excellent obstetrical consults we have. I have to say I'm very happy with the obstetrical service here, and not just because my wife is one of them, but you know, it really is true. So a couple of background important information. Trauma remains the highest cause of maternal death, okay? So what we see in the trauma bay is the highest cause of mommies dying. And about less than 10%, we say 6 to 7% of trauma patients, or of pregnant patients actually involved in trauma. Now, not all these are major trauma. It could be, a fall from standing. Nevertheless, it is still trauma. And these are some headlines from the Union Tribune, 2008. Man arrested in an attack that killed 2. One was a 17-year-old pregnant girl. Pregnant woman, 19, dies when hit by a car. I think some of you may remember this last one, pregnant woman traffic death that happened in the 5, just past the Border Patrol checkpoint. So unfortunately, pregnant women are still dying, and they're dying of trauma. And of course, we also have the baby inside. So, there's a lot of kind of social and psychological effects of the pregnant trauma patient that we all see in the front line, and you guys are really, exposed to this on a daily basis. I sometimes don't know how we do it, but we all manage to do it, and I think we do it as a team. In fact, I know we do it as a team. So what's happening at UCSD, if you notice from 1985, now part of this is we're increasing in volume too, but not necessarily. You notice that pregnant trauma is really increasing logarithmically. 2006, 2007, 2008 were about the same as 2005, a little bit higher. So we're clearly increasing. So those of you who have said, we're seeing a lot more pregnant trauma patients, we are. And from a 1985 to 2005 period, we had a total of about 26,000 patients, 26,500. 366 of those were pregnant patients, and the majority of those, as you saw on the graph, were actually in the last 4 or 5 years. The mean gestational age is about 22.4 weeks, and our mean ISS score, remember injury severity score, was 5.5. So pretty low mechanism of injury. We consider 10 to be about moderate, and then anything really above 20 to be severe, give or take. So it's a pretty low impact injury, and that's because, according to the San Diego County Trauma System, patients that have even minor trauma that are pregnant get bumped up as a major trauma resuscitation, and we want it that way, and we don't want to lose that. If you look at the etiology of pregnant trauma patients, the majority are still MVAs. Falls then are the next 10 to 15%, and then you got blunt assault, which is 10 or 15%, and then unfortunately penetrating trauma, which can be anything from a gunshot wound to sometimes just an accidental knife wound of the upper extremity. So there's still a majority of these are blunt, and the majority of these are MVAs. And again, if you kind of look at this in another study by Yacasi, if you put it into a nice graph, again, you're looking at MVAs as being about 70% of these. And we're about the same, about 60%. Falls, 9.3%. Violence, still 10%. Peds versus auto, so forth and so on, are also here. So a pretty good distribution of injuries, but most of them are MVAs. I think most of you probably already know this just from nursing school, and also those of you who have had kids. About 20 weeks, the uterus is right up at the umbilicus. And as you get higher in terms of gestational age, your uterus pushes up more. Now, why is it important for us as caring for the trauma patient? Is because as the uterus pushes up, intestinal contents are distributed laterally and superiorly, right? So not necessarily will you have direct exposure to the intestines as you would in a non-pregnant patient. And remember, the uterus is engorged with blood vessels. So if there's uterine bleeding or retroperitoneal bleeding, that could be a substantial, great deal more in terms of hemorrhage than it would be for a non-pregnant patient. So for instance, if you have patients that have a bad pelvic fracture and they're pregnant, I would expect that patient to bleed a heck of a lot more than those that don't have a pelvic fracture. Now that's never been studied, but it makes complete sense if you think about this. And for those of you who had the privilege of seeing a gravid uterus in the operating room, it's pretty impressive. These blood vessels are huge and they're nasty looking. They're curled. They're basically saying, don't touch me. Unfortunately, a Chevy doesn't know that when it hits another patient. So it's something we have to be cognizant of. Remember we talked about the lateral position? This is why. Because the baby is basically a bowling ball. So here you have the baby, here you have the baby lying and compressing the IVC between the actual spinal column and the fetus. All right. So when you're supine, that baby can compress the IVC, decreasing cardiac return, decreasing cardiac output, decreasing blood pressure, and so forth. So when you put the patient in a lateral position, the baby lifts off the IVC, and we increase cardiac return. If you look at it from an actual science perspective, here you have a patient. I really wish I had a pointer here. Here you have a patient who's supine. Okay. You tilt them at 16 degrees, and the cross-section of the IVC increases by about 40%. You tilt them at 26 degrees, it increases by 60%, and you tilt them all the way left lateral, and increases by almost 100%. Do you guys see that? That's pretty important, and that's why we do it. That's the science behind why we do it. So there actually is anatomic variation of the IVC. Now, not all pregnant patients should necessarily be lateral. I mean, a lot of our pregnant patients are hemodynamically unstable, do not have any problems with maintaining perfusion, but those patients that may be in shock, putting those patients lateral can actually increase cardiac output significantly. Pregnant physiology in the trauma patient is a little bit different, and I'll show you some graphs to show exactly why. Does anyone know, is a pregnant trauma patient acidotic or alkalotic? Or just say a pregnant patient. Anyone know? Tanya, come on. You got to know this.
Okay, I guess acidotic, so I think it's probably alkalotic.
Oh, I see. Okay, so we're gonna bet against you. Okay, all right. You're absolutely right. It is in fact alkalotic, so that'll help me in the future when you say something. Okay, good. A pregnant patient is in fact alkalotic. Okay, great. Does anyone know why? Is it a respiratory alkalosis or a metabolic alkalosis?
Metabolic.
It's actually respiratory. Think about it. You've got a big uterus. What did Tanya say?
She said metabolic.
Yeah. Okay. Perfect. So it's respiratory. Why? Because you have a huge uterus in your belly. So you have a huge uterus in the belly, so therefore the patient's going to breathe quicker. And so in fact, the patient is alkalotic, and it's a respiratory alkalosis. The body does this on purpose. This is no joke. And we're going to talk a little bit about this. Okay, so here you have on the very top, because you're breathing quicker, your ventilation is up, your minute ventilation is up, right? Because your respiratory rate is actually higher. Believe it or not, your tidal volume goes up until you're reaching about gestational age. Then your tidal volume really starts to go down because it's such a large mass. And then your respiratory rate also increases from baseline. So all this gives you hyperventilatory state, giving you that alkalosis. Does that make sense? All right, and I'm going to show you why that's going to be important in a second here. Okay, now think about your blood volume. All right, again, learn this now, and then we'll relate this to the trauma patient. To be sure, this is actually helpful in half of our patients that are in the ICU that have bled significantly in the operating room from some of the pregnancies. So this is good for a lot of things. Okay, cardiac output increases significantly, right? Not a surprise, because cardiac output is stroke volume times heart rate. Okay, so patients have a huge amount of blood volume in them. All right, this is the Mother Nature taking its course. So total blood volume increases dramatically, plasma volume increases dramatically, RBC volume increases to some extent. What about the hematocrit? Is that higher or lower in the pregnant patient?
Higher.
Yeah, bet against Tanya. It's actually lower. All right. Why is that the case? Because your volume is so much higher. Because your volume is so much higher, your hematocrit is going to be a little bit lower, so you're a little bit diluted. This is Mother's nature of bleeding. And I will tell you this, and I'll tell you this again, something is amazing in that pregnant patient because they are designed to bleed. That's why you can have a patient who has a placenta accreta, can bleed 20 units, and are extubated eating breakfast the next day. Pregnant patients are designed to bleed. It is the absolute most interesting thing that pregnant physiology confers on this pregnant lady. Okay? And this is some of the reasons why. We still don't know exactly why this happens, DNA-wise, but it happens. And it's pretty amazing. It makes humans and animals and mammals pretty amazing creatures if you think about it. Okay, so here's a classic ABG finding in a stable pregnant patient who's nearing gestational age. Your ABG is 7.48, right? Your hematocrit is going to be 40%. Now notice your CO2 is 33 instead of 40 to 45, right? Because you're breathing quicker. PaO2 looks basically the same. Hematocrit's a little bit lower because your volume is so much higher. Your white count's actually a little bit elevated, and we call that leukocytosis of pregnancy. I don't really know why, but there is that leukocytosis that we see. So sometimes if we see a white count that's higher, we don't necessarily think the patient has an active infection or something like that. That's just pregnancy. We do look at the shift in the bandemia, and their blood pressures tend to be a little bit on the higher side, but certainly not more than 130, because then you start thinking about preeclampsia and those things. Okay, now, you guys know about classes of shock. I know you guys have looked at that in the past. When we talk about class 4 shock, these patients lose about 2 liters of blood, and their blood loss is over 40%. Their blood pressure goes down, their respiratory rate goes up, their urine output drops, and they get really lethargic and kind of wacko, okay? Comatose, you can say. Interestingly enough, in the pregnant patient, the first signs of maternal shock, that is to say, blood pressure, change in lactate, all those types of things, occurs after about 40% of blood loss. Again, the pregnant mother is designed to bleed, right? The average blood loss in delivery used to say about 500 cc's in a cesarean section, about a liter. So you can imagine, and patients are totally stable, that's just the average. So pregnant women are designed to bleed. So they will bleed and bleed and bleed and bleed and still be normotensive, still not have any signs of shock, because remember, they're alkalotic. So they don't want to be acidotic until you get to a certain point, and then bam, they drop off the curve just like a kid does. All right, so they're very well compensated until they reach that point, and then it's all over. And fetal hypoperfusion happens before maternal shock. Okay, so that's another thing you have to be cognizant of. Is that mothers will bleed and bleed and bleed, but the fetus will actually have problems before the mother displays hypotension. All right, remember, you save the mother, you save the baby, and that's a good example why. Okay, you guys have seen this probably in nursing school, and then those of you that have some OB experience, we know that this is the placenta. You have the villi, which are fetal in origin, into the uterus. You have the uterine wall. You have this wonderful, mysterious, and it's still mysterious, frankly. Even experts in this field don't quite know how the placenta works. You have diffusion of particles from maternal blood flow into the fetus blood flow. And then you've got the amniotic sac, amniotic fluid, and more specifically and more importantly, we've got the whole unit of the placenta, and I'll show you how that's important. So uterine blood flow does not have autoregulation. Things don't necessarily contract and constrict like they do in the brain or like they do in the peripheral vasculature. And fetal blood flow, accelerations and decelerations of fetal heart tones are directly correlated to uterine blood flow, right? So trauma to the uterus can promote the release of arachidonic acid and can cause uterine contractions and can alter blood flow. And that's why the fetus can have decelerations and accelerations after trauma and pregnancy. So fetal survival decreases to less than 15% once the mother is having signs of shock, right? Increased acidosis, higher base deficits, persistent hypotension, and therefore, save the mother, you save the baby, maternal well-being is crucial to fetal viability. Okay, does that make sense to you guys? Do you understand the science behind why this is the case now? All right. Okay, so it's the same, ABCDs. Save the mother, you save the baby. Supplemental oxygen can be helpful. No proven data, but it makes sense. We talked about putting a patient in the left lateral decubitus position to prevent maternal hypotension, right? And of course, we want to have rapid OB consultation. Should never interfere with the primary and secondary resuscitation, but then they're a very close second, okay? And I'm going to show you some other data about what exactly they do and what are some of the problems that can occur. What does the OB folks do? A cervical examination, sometimes, not all the time. Fetal heart tones for sure, especially if they're greater than 20 weeks. You guys know 20 weeks is kind of the cutoff for fetal viability, right? So more than 20 weeks, patients are generally put in LND to watch fetal heart tones. Less than 20 weeks, generally the fetus is considered unviable, okay? Remember the physiologic differences of pregnancy. Patients are a little bit more alkalotic. They have higher heart rates. Their volume is much higher. Respiratory rates are much higher. And during the ultrasound, they're going to assess for a rupture of chorioamniotic membranes. I'll show you some pictures of that in a second. Okay, so obviously we worry about maternal fetal hemorrhage, and I'll show you a little bit about what I mean by that. Do you guys know what Abruptio placenta is, or placental abruption? Okay, right? So the placenta strips away from the uterine wall, so you get abruption of the placenta, and you get a lot of bleeding between the placenta and the uterus. That's very dangerous. And there's something called an amniotic fluid emboli. Are you folks aware of what that is? Those of you that have had a lot of OB patients realize it's the result of amniotic fluid entering maternal circulation and causing an anaphylactic response. We don't know exactly the pathophysiology behind it, but it can cause sudden hemodynamic collapse, almost like a massive PE can, very similar. It's very rare. It happens in about 1 in 80,000 pregnancies, and it can happen in trauma. There are some case reports showing that. So if by any chance we see a patient, pregnant patient, all of a sudden collapsing with no evidence of real bleeding, one has to think this may be a possibility, okay? Something to think about in the back of your mind. Okay, now let's talk about FMH. You guys may or may not remember. Do you guys remember why we give RhoGAM or why we check RH? Okay, I'm going to go through step by step exactly why we do that so it's crystal clear. It's a really interesting concept of how we do it. By the way, does anyone know historically one of the most famous people that were likely RH negative? I will give I will buy someone chocolate for this. But not just Hershey's. I'm going to buy you, Okay.
What's the question again?
Who's one of the most famous historical figures that was likely RH negative? Okay, so now the chocolate's off the table, but I'm going to tell you she was wife of a famous English king. No, ma'am. Victoria had a lot of kids.
Josephine.
Nope. No, not Anne Boleyn, but... No, not Catherine Boleyn, but Catherine of Aragon. Okay? She had a first daughter, right? Mary, Bloody Mary, who eventually killed a bunch of non-Catholics. All right? But she could never have a child afterwards. And some people think it's because she was Rh negative. She was sensitized, became Rh positive antibodies, and every subsequent baby became fetal demise. Right? Anyways, a little bit of history to make it. So let me go through this in detail. All right. Okay, so an Rh negative mother, remember this is only for those who are Rh negative, has an Rh positive baby number one. Let's say the father is in fact Rh positive. It's a dominant trait, so the baby will be Rh positive. Okay, now you get a trauma event that causes mixing of the fetal and maternal blood. And I'll show you how we detect that in a second. Now the Rh negative mother makes Rh positive antibodies. So far so good? All right. Rh mother, now with Rh positive antibodies, has an Rh positive baby. Baby number one delivers. Everything's great. Now, Rh negative mother with Rh positive antibodies has a second baby now in gestational age. The baby is Rh positive. What happens is that Rh antibodies from the mother cross the placenta and attack the Rh positive blood cells of the baby, causing lysis. Does anyone know what that causes in a baby? It causes something called Hydrops Fetalis. Okay? So the antibodies from an Rh sensitive mother with a future Rh positive fetus can result in Hydrops Fetalis. I'm going to show you a terrible picture. So what happens is that the baby becomes, all the blood cells are lysed. The baby gets basically cardiac failure and becomes very edematous. I'm sorry to show you this picture, guys. I know it's disturbing, but it is important that we see this. This is what can happen. That's why we're very sensitive about patients getting RhoGAM if need be. Okay, so what does RhoGAM do? And we'll show you how we detect maternal fetal hemorrhage after the trauma. RhoGAM is an antibody against an antibody, so to speak. Not quite works that way, but kind of. And so what that does, it blocks the mother from seeing the Rh protein of the baby. So it blocks it. So the mother never sees it, so therefore the mother never makes antibodies against Rh. Does that make sense? Okay, so therefore, the mother remains Rh negative, of course. She never has antibodies, and now when baby number two comes along, the mother's antibodies never cross the placenta, never destroy the baby's Rh positive blood cells. Baby delivers normally. That's why we do RhoGAM. So does anyone know the test we send off? Tanya? Yes, excellent.
I know this because I'm Rh negative, so I know.
Did you get Rogaine?
I got it a lot because I had bleeding a couple of
Right. I remember.
I've had it a lot.
I remember you mentioning you got Rogaine before. So, Klein-Howard-Becky. Okay, let's talk about what that shows. Now, a Klein-Howard-Becky test takes maternal blood and fetal blood, because of the way fetal hemoglobin stains darkly. So you see all the dark stainings here? That's fetal blood. And one fetal cell per 1,000 maternal cells corresponds to 5 mils of fetal hemorrhage. If you do the math, that's what it turns out to be. Only 0.01 mils of fetal blood can cause RH sensitivity. All right, so that's why we're very anal about getting a Klein-Howard-Becky test in a patient, especially if they're RH negative. Okay? And then we give Rogaine. It's 300 micrograms for every 30 mils of fetal blood within 72 hours, and dosing can be dependent on certain things. All right, so that's fetal maternal blood-blood mixing. Abruptio placentae or placental abruption, it's less than 5% of all trauma patients, but it can be up to 50% of causing fetal demise. And here you have the placenta, it's normal, but now you see the blood between the placenta. It's going to be hard for me guys because I don't have a pointer, but you see the blood here starting to develop? And that blood can expand, and a patient can lose a lot of blood in that region. Okay? So, patients should undergo 24 hours of fetal monitoring, especially if they're greater than 20 weeks. The books will say 25 weeks, but here we do generally 20 weeks. Tocolytics are not necessary since most contractions that you get stop. Operative indications are no different from any other trauma patient. And of course, perimortem cesarean section is a terrible thing. If the mother's dead and you try to get the baby out, most of those babies don't make it. So a classic surgical board question, you have a pregnant lady who's 23 weeks pregnant, gets shot in the abdomen, what's your next step in management? Next step in management is you operate. It doesn't matter what the pregnancy is, you still take care of the mother. Okay, let's talk a little bit about radiation, then I gotta run. If necessary, radiation for diagnosis is not contraindicated in a patient, especially if maternal well-being is in jeopardy. Okay, that's important. Remember, you save the mother, you save the baby. In general, 5 to 10 rads carries no increased risk in fetal morbidity. There's no evidence of growth retardation or congenital malformation. These are based on Hiroshima studies after the bomb. Now, let me just show you down here in the yellow. Chest X-ray is only 0.05 rads. A CT head is only 0.05 rads. A pelvic X-ray is only 0.4 rads. A CT abdomen pelvis is a little bit higher. It's 6 rads. So we try to avoid that unless you absolutely need it. All right? And 5 to 10 rads, again, carries no increased risk. Really, when you're above 10 rads, that's when you start worrying about it. So you could scan a lady up and down and still have very little increase of risk, almost nominal, causing fetal growth retardations or fetal congenital malformalities or fetal leukemia in the future or childhood leukemia in the future. All right? So that's why, even though we're very cautionary about actually exposing the mother to radiation, the radiation dose is so low that in a trauma workup, and this is going to be published soon in the Journal of Perinatal Medicine, the trauma workup has very little increase in actual fetal dose exposure. Okay? So remember that X-rays are okay, CT scans are okay, and you save the mother, you save the baby.
This has been studied on kids that are old now.
Here's the problem. It's only been studied on kids that are older after Hiroshima. How do you study this? It's really hard to do this. So we do have good longevity information on those that were exposed to the bomb in Hiroshima in 1945. So we have almost 65 years or 60 plus years of studies on this. So it's a little bit tricky because after all, the bomb is very different from an X-ray. There are some studies that are looked at the folks in Chernobyl, but again, it's limited. So a lot of these information, including the things about CAT scans and whole body CAT scans and all that kind of stuff, increasing your risk of leukemia or cancer, is all based on Hiroshima studies. Okay, so again, out of 282 patients we looked at UCSD, the mean total radiation was 344 millirems. Millirems, 0.03 rems, right? Very small amount. And the radiation is much, much less than the 5,000 millirems considered the threshold. Okay? So rest assured that our patients aren't getting zapped to severe levels. Here's kind of an interesting fact that most pregnant patients do very, very well. All right? Out of 77,000 pregnant patients that were looked at had trauma in the National Trauma Registry base, those that were pregnant were about 1,200. The vast, vast, vast majority of those survived. Only 17 out of 1,200 patients actually died. Okay? And those that had a high risk of pregnancy loss were only 66 out of 1,200 patients. So the vast majority of pregnant trauma patients do very well. And that's really, I think, secondary to the work that all of us do here and making sure these patients do well. Okay, so finally, the priority must be given to the mother. Save the mother, you save the baby. Pregnancy physiology is unique. We talked a little bit about that. We talked about the ABGs, we talked about the heart rate, we talked about the respiratory rate, talked about the hematocrit. And obstetrical consultation should be obtained properly to look for things like Klein-Howard-Becky tests, to look for things like placental abruption, and to make sure fetal hard tones are acceptable. Okay, I have time for a few questions. Tanya.
I just want to know, because all my pregnant people that have come in have always been really stable. So if you get a mother that's in shock and she's lethargic and the baby's heart is slow, are you going to just go to the operating room? Would you ever do like a C-section there and then do an X-op in the operating room?
No, well, a lot of it will depend what the reason is, right? We don't just whisk a patient off to the operating room unless they have like a gunshot wound or absolute bleeding in the belly or the chest or something like that. Most of the time, we still do our ABCs. So nothing changes.
And you do an X-op without disrupting the uterus at that point?
Yeah, we try. It's hard, but you try. Yeah.
So if they're like leaking blood and we know we're just going to be planning on going to the operating room?
Nope. You're going to do your ABCDs. Nothing changes. Make sure you get 2 large bore IVs. Start with lactated ringers. Call the blood bank for blood if we think the patient's hemorrhaging. Do a good assessment. Try to find out where the patient's bleeding from, just like we would for any other trauma patient. And that's important. When you see a pregnant trauma patient that's sick, and we'll see 1 or 2 of those in the next 5 years, let's not lose our cool. Let's do the exact same thing that we would do for any other patient. Save the mother, you save the baby. If we start changing our algorithm, if we start changing things, then we're going to get in trouble. Any other questions, guys? Okay. Thank you very much.